So our next case is a 59-year-old lady who has recently been diagnosed with atypical esophageal melanosis, initially presenting with epigastric pain. So a private OGD was performed on the 30th of October, showing multiple dark pigmented, slightly elevated lesions at the middle third of the esophagus, around 21 to 23 centimeters from the incisors. Biopsy showed atypical melanocytic proliferation, and a PET-CT was hence arranged. No obvious FDG avid mural lesion was identified in the esophagus, and there was no evidence of tumor extension to the periesophageal fat and no regional lymphadenopathy. A narrowband imaging magnifying OGD and endocystoscopy was performed on the 27th of November, showing again esophageal melanocytes located at the 21 to 22 centimeter and also the 23rd to 25th centimeter. Endocystoscopy was also performed, and it was compatible with melanocytes with some mild dysplasia. From the endoscopic photos, it did not show that it involved the deep layers. And so these are images from the OGD as well as the endocystoscopy. And today we'll be performing narrowband imaging magnifying OGD together with endocystoscopy and also endoscopic submucosal dissection.
Hi, good morning. Hello.
Good morning.
Yes. Hi, now I'm with Professor Kenshi and Dr. Honji Yip, and we are having this patient. You have already heard the history, and if you have the endoscopic view, then you can see actually this is 20 centimeter from the incisor, and when I'm advancing the scope at 21 centimeter, we started to see some dark area. So we haven't stained anything on the esophagus, but we can see quite dark patches. So one is over the 6 o'clock, the other is around 12 o'clock. And when I'm doing the diagnostic white light endoscopy, you can see the extent of this dark area. So the first one is from 21 to 22 centimeter. The other actually on the other side is from 23 all the way down to maybe 25 centimeter. So as you heard about the history from the biopsy, it shows atypia in the melanocytes. So we are actually quite worried that this may be esophageal melanoma, which carry quite poor prognosis. So today I'm having the Olympus latest version of the endocytoscope. So when I actually can come close, and when I switch to the MBI mode, in fact, we have a discussion just now with Professor Yao, whether there's a presence of the IPCL or not. So Kenshi, what's the importance of presence of the IPCL?
So since the IPCL is very well preserved, so that tells you a tumor or something is located just underneath the epithelium, including papilla. However, we can't visualize branched vessels. That means a tumor is still located lamina propria mucosa. I think this is a sign for determining the depth of the tumor. So
okay, yes. So now I think we are in the endocytoscopy mode, and I'm now around the dark area, and you probably appreciated that there's some dark area of nucleus and also cytoplasm here. And maybe it's represent a little bit atypical in the arrangement in the and the cytoplasmic appearance. This is without any of the stain, and we prepared the methylene blue and also the crystal violet for the staining.
But this tumor itself has some pigment.
Yes.
So it is a similar effect to staining. So
yes,
we can predict the morphology of the cytoplasm of the cells according to the pigment. So according to such pigment findings, the tumor cells are really heterogeneous in size and shape. So that means it can be malignant.
Yes, yes.
Philip, Tajili speaking. Can you hear me? Tajili speaking. Philip, before observing endocytoscopy, did you sprayed methylene blue and crystal violet?
Yes, I wanted to do that now. So before that, in fact, I wanted to show the effect. For example, like when we are actually having the MBI, in a normal area like this, we can actually observe the IPCL pattern. So here, actually, you can see this is a normal.
What is the magnification?
You can, yes. Yes. So these are the IPCL that you can see even without the staining. But I think if you want to observe the cytoplasm and the nucleus, it's better to stain. So now we are using the methylene blue for the staining and also coupled with the crystal violet. So I have a spray catheter with me. You can actually spray through the catheter or actually through the scope. Is it the same protocol as you do?
Yes, I think so. So have you ever tried to this region?
Okay.
No.
Spray. Spray.
It's a methylene blue.
Okay. Yes.
Philip, this is a methylene blue.
Philip.
Yes, it's a methylene blue. Yes. Yes.
So methylene blue first.
Methylene blue first, and afterwards we'll stain by the crystal violet. So it's a double staining.
How about the concentration percentage of methylene blue? 0.2.
Concentration. So we are now using 1% of the methylene blue. So it's quite concentrated here, but from our experience, it's quite effective in the staining. So and then the crystal violet. Crystal violet will be 0.025%. So confirm with Honchi. Okay.
CM staining is reported by Dr. Minami from Japan. So they use a dual staining. When methylene blue will have very good staining of the cytoplasm as well as the nucleus. The crystal violet added more effects in the contrasting the cytoplasm with the nucleus. So a double staining gives the best effects when you do endocytoscope.
Okay. Okay.
But this is just my concern. So if you see in the epithelium the tumor underneath, it's become unclear.
Yes, maybe. Okay.
But just wait and see.
Yes, we have to wait a little bit so that the stain will react with the cell for staining.
Philip, we will switch back to Rob Halls for a moment and then we'll come back.
Okay, thank you.
Philip, we are back.
Hello. Hi. Okay, so the stain is now working. So if you recognize here, at the central part, that is the previous observed melanoma, suspected melanocyte area. And when I do ultra magnification with this endocytoscope, in fact, we'll be able to see these are normal squamous mucosa because the arrangement of this nucleus, the NC ratio is normal, and the nucleus is not heterogeneous in the size and the shape. And then afterwards, we actually can move towards that area of the suspicion of the melanoma. So that is at the central part here. So when we
Philip,
come up,
what is the magnification of the endocytoscopy? Is it 1,000?
yeah, actually 500. Yeah, so it's almost like 1,000. Yeah, almost. So here you can see this is the abnormal area. So if you compare to the previous squamous cell, then this is very abnormal in terms of the cytoplasmic arrangement. I think we already seen that before. So, but actually the area is also covered by some normal squamous mucosa here. So I think this is very interesting.
Yes, quite interesting.
Yeah. So when we press a little bit harder, then actually we can see some melanocytes at the background here. So this is, I think it's a combination, and the melanocytes actually will be located within the squamous mucosa as well. So
right,
like that.
This is something like tomography.
Yes. Yes.
Endocytoscopic tomography.
Yes. So I think currently with the evidence of the presence of the IPCL pattern and also the squamous mucosa, I think we will be amenable to endoscopic resection so that we can have a better histopathology, and we can then decide if the patient needed surgical treatment.
Yes, it's a very good indication.
Yes.
And I noticed that the tumor or underneath cells quite similar to that of histological finding of malignant melanoma.
Yes. Yes.
Quite similar, but just by cytoplasm shape.
Yes. So Professor Yao's brother is a pathologist. So I think on day 3 we will prepare this specimen for him for his real-time assessment.
Yes, it's exciting.
Yes. Okay. Okay. And any questions?
Philip,
Yes.
Philip, can you explain a little bit more? How did you change the focus from the
Yes.
squamous cell layer to the melanocyte layer?
Yes. So if you can actually look into the scope, there's a liver, and this liver, when we actually pull it down, the magnification will change.
Can we close up a bit more on your hand?
Yes, this one. Yeah.
Can
Okay.
we close up a bit more?
So I think the technique is important. This is a endocytoscope, so it's a contact endoscope. So we don't have any cap at the end. So we have to push the scope all the way to the in contact with the mucosa, and then afterwards, when we are pushing this, actually pulling this liver, we can adjust the magnification. So it can actually go all the way down. So there's a change in the depth, a little bit of the magnification. But you still focus on the superficial layer.
So it is the same lever that gives you both the magnification as well as the depth of the focus.
Yes, you can consider this as an ultra magnification from the macroscopic to microscopic and then to cellular level.
So focal distance is really narrow. So we can get some tomography view using the different magnification rate.
Yes.
This is the point.
Yes. But you have to be very careful in control of this leverage, because a slight change will actually change your focal length, and then you have a different focus. Okay. So
the plan is for ESD later on during the day or tomorrow.
Yeah, probably we'll prepare and we'll do the ESD now.
You will do the ESD now? Okay.
Yes.
Philip, tactically speaking, the purpose of dissection is its region is just the pathological diagnosis.
Yes.
It's right?
Yeah, actually, I think we seldom see this lesion, but when we are seeing this, most of the time they are in the advanced stage. So the biopsy only show a TPR, so we think that first of all, we wish to confirm the diagnosis with a better pathology, and secondly is if there is only a melanocytes with a TPR, probably endoscopic resection is adequate. But we have to see the final histopathology. I think this is important. So if any suspicions, for example, lymphovascular permeation for this melanoma, then we would discuss with the patient for esophagectomy.
Okay, Philip, while you're changing the scope, we'll go to another room. We'll come back later.
Thank you. Okay.
Philip, we're back to you.
Oh, hi. Hello. So now we have prepared the ESD procedure, and we have already marked around the lesion. So here is the proximal lesion, and this is the distal lesion. So we try not to completely circumferentially resect the two lesions. We just do the appropriate amount of the resection, because we don't want to have induced stricture. So now we already injected around the lesion, and with the normal saline indigo carmine and epinephrine in mixture with sodium hyaluronate. And today I'm using the dual knife with injectable power. So during the dissection, I can actually inject more of the normal saline with the indigo carmine. Okay. So needle out. Okay. So we start the cut. I think just now Kenshi reminded me that I should actually mark the two lesions, because after injection of the first lesion, probably there will be some blurring of the margin. So the diaphragm meter I'm using is the Irby 300D. So now I'm doing the endocuts with around the mucosa, and you can see the exposure of the submucosa. Actually, there's some muscularis mucosae before the submucosa, in the esophagus especially. So sometimes it can bleed. Inject. Inject. Yes. So yeah, inject. So not yet prime the channel. So afterwards we know. So the injection can actually be done by both the water pump or by manual. So currently we is done by the manual. Okay, enough. Needle out. So you can see a little bit of the big vessel, but we can tackle it with the coagulation mode. I think in doing the esophageal ESD procedure, one of the key is to stay in the right plane. But I think we learn a lot from the tunneling procedure from the poem. So in fact, sometimes if it's circumferential, we develop a few tunnel before we actually continue the dissection and complete the dissection. That actually provides us with a more stable dissection plane. But today I don't need to develop the tunnel for this lesion.
Philip, can I ask just one question?
Yes?
Why do you decide you should approach from the proximal region?
Yes, I think it's my usual conventional method that I actually start from the proximal side to the distal end. And in the past, I also complete the circumferential mucosal incision, but right now I think there's a lot of different technique being developed, including the pocket creation method. And I think we don't need to completely open up the mucosa. It has the advantage that some mucosal solution and the cushion will be retained longer. So it's easier to approach from the oral side to the anal side.
Sorry, my question was from the proximal region instead of distal region.
Yes.
The other side.
Yes. So from the start from the more proximal lesion. Yes. I think that is because firstly this is an easier and smaller piece, and secondly is after I dissect this, I would just go on and continue the lower part. Maybe because it's a close proximities, I don't know whether I can actually separate the two or actually I can join the two together. Inject.
Thank you.
Okay, enough. Okay.
There is some coffee outside. You can go and grab a cup of coffee while they are working on the ESD. And the next didactic lecture will begin at around 10:30.
So you may notice that I'm now using the dual focus mode for the observation. So when I'm doing the submucosal dissection, it's my common practice to use the near focus so that I can focus on the submucosal, especially over any of the potential bleeding vessels so that I can coagulate before I cut. So this whitish muscle layer is in fact the muscularis mucosae. Sometimes it gets very thickened, I think especially in the patient with achalasia. So okay, inject. Okay, enough. Inject. Okay, enough. Okay, inject. Okay, enough. Any question? Anything discussed? So now I'm trying to dissect around the lateral border of that lesion. So maybe I need a little bit more of the injection. So this is not a very big piece of lesion, but I think it's better to do it on block resection. Arguably, you can do it by EMR in this case, but I think because we worry that there's a margin, so it's better to do with the ESD.
Yes, on block resection is ideal.
Okay, needle out.
Philip, we have to
Inject.
move to the lecture session.
Yes.
We'll leave you to work.
Thank you.
We might come back after the first lecture and see a little bit of it.
Thank you.
Thank you.
Hi. Hello. Yeah, James. So now we have completed the first ESD. If you can see the endoluminal view. So, okay. Yeah, this is a specimen. So we have completed this, and you can see there's some darkish area at the center. And so now we show you the macroscopic view, but 2 days later we'll have the histopathology examining this specimen and also the other piece. So stay tuned for 2 days later, we'll have a real-time examination. So right now we are doing the second lesion, which is distal to this and a larger piece. We have already marked around the lesion, but initially I wanted to spare a skin bridge, mucosal bridge, so that to reduce the amount of stricture. But right now I can see probably this bridge cannot be spared. So we need to take a part of this, mucosal bridge. But we will continue the procedure and the same procedure of the previous same ESD. So in the esophagus, and we'll start from the oral side and then dissect to the anal side. Okay, inject. Yes. Okay. Thank you.
Philip.
Yes.
This is Helmut. May I ask?
Oh, Helmut. Yes.
Did you experience some submucosal infiltration, or it's quite easy to dissect?
It's quite easy to dissect. So I think that, well, from our experience, from the appearance of the submucosa, it doesn't look like any deep invasion. Of course, we have to examine with the pathology about the superficial one, but probably it doesn't look like there's an invasion. So I generally use a coagulation mode.
To do an ESD is justified? Probably
Yeah,
yes.
I think so. We would do the same. Yeah. I mean, esophagectomy is really
too morbid.
Yeah, and if it's curative, I think it's the best for the patient. Sure.
Yeah, Helmut, you have done the large series of ESD for Barrett's esophagus, right? Yeah. Inject.
So this is rare.
This is
okay.
rare in your country, not in our.
Not Barrett's, but I mean
melanoma is absolutely rare. Never saw this case before, so I'm quite excited.
Oh, okay.
About the pathology.
Philip, I think we probably move on and we'll move to the other room because there are a few. We'll go back to Philip, and obviously he has done his ESD.
Yes, James. We finished the ESD. Initially, I thought that we can spare some of the mucosal bridge, but finally we cannot. So there is around maybe 2 centimeter of circumferential area, maybe 2 or 3 centimeter, and then afterwards is completely resected. And you can zoom in here are the 2 specimens that we have resected with a dark elements at the center representing the melanocytes. And now we decided that because we have circumferential, we would like to inject a steroid to hopefully reduce the chance of the, or the severity of the stricture. It's very likely that the patient may got some stricture formation after the ESD. So now we are having the Kennecord solution. So and we have diluted it to 10 cc. And we'd like to start by injecting at the submucosa. So needle out. Inject. Okay,
Do you
enough.
also prescribe oral steroids for these patients?
Yes, I think there are studies showing that also oral steroid will be effective, and some protocol will be giving oral steroid regularly. But for us, we would like to conduct earlier endoscopic dilatation starting on the week 2 after this ESD. Needle out. Inject.
And here for your
Okay,
submucosal injection, obviously you go to the sides because you need to inject it submucosally. And
yes,
so
exactly.
Within the resected bed, there's no submucosal.
Yes. Inject. Okay, enough. Okay, so maybe a few, 0 point something cc every edge. Needle out. Inject. Okay, enough. Okay, needle out. Inject. So I already conducted the coax grasper and to do the hemostasis already. Needle out. Inject. Okay, enough. Okay. Okay. Inject. Okay, enough. So needle out. Inject. Okay, enough. Okay. Okay, needle out. Inject. Okay, enough. Okay. Okay. Needle out. Okay, inject. Okay, enough. So how much we got? Okay. Needle out. Inject. Okay, enough. Okay, so because of the dissection, sometimes there's some spillage of the steroid. Needle out. Inject. Okay, enough.
Philip, you tried to leave a small tongue of normal mucosa, but obviously it was not possible.
Yes. Needle out. Do you do this, Helmut?
Yeah. Initially, you said you will leave a small tongue of normal tissue between the two resection areas.
Yes.
Obviously, it was not possible.
Unfortunately,
so,
yeah. Needle out.
I mean, we did some studies on using systemical steroids in patients where we didn't have a circumferential dissection, and we could avoid stricture in all cases if we tapered the dose over 6 weeks very slowly.
I see. So what's the dosage of the steroid for the systemic one?
Start with 50 milligrams.
50 milligram, yeah.
Yeah, and go down every week by 10 milligram. And then make a control endoscopy every 2 weeks.
I see, okay.
And gave steroids until the whole area is healed and no ulcer is present. Then we stop steroids.
I see. Inject. Okay, enough. Needle out.
If you add control endoscopy, you see that it's a little tight.
Okay,
Can you dilate?
Yeah. Usually it's enough if you dilate with the scope. So no balloon dilatation is necessary at this stage.
I think we have already injected maybe 10 cc. Yeah. Okay. So I think we finish here, and we'll have the pathological examination of the specimen later on.
Yeah.
Thank you.
Okay.
Very nice.
Thank you.
Great. Wonderful.
Thank you.